We are live now, doctor.
Yeah, thank you, Manjula. Good evening and warm welcome to everyone joining us for this Ophthalmic Horizon webinar today. And it's my privilege to welcome all of you for this postgraduate update program on fundus cases. And as we gather here, we would like to acknowledge the heart of this event, our postgraduate students in ophthalmology. And it is with their fresh perspective and dedication to learning that we truly embody our theme, together we grow towards excellence. So I request the postgraduates to actively participate and absorb the wealth of the knowledge that will be shared here today. And you are an integral part of this journey towards excellence, and your contribution will shape the future of ophthalmology. And have a great privilege and gratitude to our panel of examiners today. Professor V.R. Vijayaraghavan, who has joined us to share his extensive knowledge in postgraduate examination, particularly fundus cases. Also welcome Dr. Professor Parthiban, Professor of Ophthalmology from Trichy. Thank you, Parthi, for joining us.
Thank you, Nirmal.
Also welcome Dr. Sriram Gopal, retina surgeon and our foundry secretary, and Dr. Saravanan, Dr. N. Kasanajan, and Dr. Manoj Khatri, all eminent retina specialists who have gracefully accepted our invitation to be part of the panel of examiners to share their experience and expertise with us. I also welcome all our managing committee members who will be joining us today. A special welcome to Dr. Sivagami, who will be moderating this session, and Dr. Sharmila, who's the convener of this program. Thank you, Sharmila, for taking all the efforts to bring this program together. And to our presenters today, Dr. Temangani, Dr. Shruti Devi, Dr. Niveda, and Dr. Neela Priyadarshini. So thank you for bringing your detailed cases for us to discuss and learn from. I'm sure today's presentation will be a good learning experience to all of you, as well as to all our viewers. To all our participants today, your enthusiasm for knowledge and commitment is what makes events like this a success. So this is again our yet another program to help our postgraduate to be part of this journey. Together we can grow and elevate the standards of eye care. So thank you all for being here. Let's, without much ado, let's begin this educational journey. Thank you and welcome to this program. Over to you, Dr. Sivagami, for taking this program forward.
Yes, sir. Thank you, sir. A warm good evening to one and all. We have a one-of-a-kind presentation concentrating only on the fundus to do away with the fears and tears of the postgraduates. The first case will be discussed by Dr. Temangani from Villupuram Medical College. Dr. Tema?
Yes, ma'am.
Manjula, ma'am, you can share the screen.
Good evening, ma'am and sir. Today I'm going to present a fundus case. Fundus examination of right eye with direct ophthalmoscope at 1 arm distance showed a good red glow, and then close to face, media clear, disc vertically oval with pink in color and well-defined margins with horizontally oval cup with a CD ratio of 0.4 with healthy neuroretinal rim, and a fine irregular arborizing lacy font of new vessels are seen along the infronasal arcade within 1 disc diameter, suggestive of new vessels over the disc, and vessels that are arising from the center of the disc branching dichotomously with a AV ratio of 2:3. Macula, deep pinhead red lesions seen half this diameter.
Manjula, could you move to the next slide, please? Thank you. Thank you.
Seen half this diameter superior to the macula, and a waxy yellow lesions with a discrete margin seen 1 disc diopter temporal to the macula with adjacent retinal thickening suggestive of clinically significant macular edema with the absent foveal reflex. And background retina showed multiple deep pinhead lesions with a distinct multiple deep pinhead red lesions not continuous with the vessels, suggestive of dot hemorrhages seen in all 4 quadrants, and multiple waxy yellow lesions with the distinct margins arranged in clumps seen along the supratemporal and infratemporal quadrant, suggestive of hard exudates, and multiple superficial yellow fluffy lesions with variable size with indistinct margins, suggestive of cottonwool spots in all 4 quadrants. Examination of left eye with distant direct ophthalmoscope at 1 arm distance shows good red glow, and close to face showed media. Ma'am?
Manjula ma'am, can we move to the next slide, left eye?
Sure, doctor. Please let me know the next, doctor, please.
Yeah. Left side, next picture. Okay, thank you.
Media clear, disc vertically oval with pink in color, with well-defined margins, and horizontally oval cup with CD ratio of 0.4 with a healthy neuroretinal rim. Vessels that are arising from the center of the disc branching dichotomously with the AV ratio of 1:3, and fine irregular branching of existing blood vessels are seen along the supratemporal arcade, suggestive of intraretinal microvascular abnormalities. Macula, deep pinhead red size deep pinhead red lesions and yellow waxy lesions with distinct margins are seen along the superior temporal and inferior to the macula with adjacent retinal thickening, suggestive of clinically significant macular edema. Background retina showed multiple deep pinhead-sized red lesions not continuous with the vessels, suggestive of dot hemorrhages seen in all 4 quadrants, and yellow waxy with discrete yellow waxy lesions with discrete margins are seen along the supratemporal and infratemporal arcade, suggestive of hard exudates, and multiple superficial yellow waxy lesions with variable size and with indistinct margins are seen in all 4 quadrants, suggestive of cottonwool spots. And my diagnosis is right eye early proliferative diabetic retinopathy with clinically significant macular edema, and left eye very severe non-proliferative diabetic retinopathy with clinically significant macular edema.
Okay, Tema. Very neat presentation. Now, how old is the patient?
Ma'am?
How old is the patient?
56, ma'am.
56. Is he a hypertensive also?
I didn't ask that history, ma'am.
Okay, how long he is a diabetic, ma'am?
He is diabetic for the past 5 years, ma'am.
5 years. Okay. So a 56-year-old male patient, diabetic for 5 years. So with this,
he is diagnosed as diabetic for past 5 years.
5 years.
What is the blood sugar status? In the history, is it been mentioned, ma'am?
He is not on regular treatment, sir.
So what is the blood sugar level?
He is on
But it's important, no? Blood
his
sugar
fasting,
level.
yes, sir. His fasting blood sugar is 286 and postprandial is 378, sir. Mm of mg per year.
Okay. So uncontrolled.
Diabetic retinopathy itself shows no prolonged high glycemic levels in the sugar predisposes to PDR. Yes, sir.
Okay. So how would you like to proceed with this patient? What investigation would you like to advise for this?
I want to proceed with systemic investigation, systemic blood investigation with complete blood count, hemoglobin, fasting postprandial blood sugar levels, and HbA1c, and renal function test, along with urine routines.
Why do you want to do the renal function test, ma?
To rule out diabetic nephropathy, sir.
Anything else? Would it help you to do the renal status for this patient?
Whether he's hypertensive, whether his renal parameters are under control, whether his anemia is under control. Why do we look for all that?
For if I'm proceeding for any FFA,
Yes.
renal
That is
clearance
very
or
So why would you like to do a fluorescein angiogram in this patient? Why would you like, what you were expecting in a fluorescein angiogram?
to differentiate between my intraretinal microvascular abnormalities and new vessels, sir, and area of non-perfusion and non-perfusion areas, and to look for non-perfusion areas.
Because in this case, if you see an asymmetric presentation, because right eye you said proliferative disease and left eye is a non-proliferative, severe non-proliferative. So sometimes
Yes, sir.
subtle new vessels can be picked up with a fluorescein rather than a clinical fundus.
Yes, sir.
So that's why angiogram is mandatory in this case to rule out a proliferative disease in the other eye. And what are the other role of an angiogram in a diabetic retinopathy? You said want to find out the new vessels, to between IRMA and new vessels. Anything
Yes,
else?
sir. To focal or a diffuse leak, to rule out
Okay.
any focal or diffuse leak, and to rule out the capillary non-perfusion areas, or to rule out ischemic maculopathy,
Yes.
increased FAZ zone.
Yes, that is more important because you might have a macular edema, but the vision may not improve. That may be because of a macular ischemia. And macular ischemia can be shown only by a fluorescein angiogram. Right. And how do you like to proceed for this? What are the other investigative modalities you are finding? Fluorescein angiogram, what else?
Then OCT macula, sir.
OCT
OCT
macula.
macula to rule out center involving and non-center involving macular edema.
And what are the findings?
And
what are the findings you expect
Yeah.
in an OCT?
there may be increased central retinal thickness, or we can look for any disorganization of inner retinal layers, sir. In hyperreflective foci in the OCT.
Okay.
Then
How do you classify the macular edema based on OCT?
spongiform macular edema, cystoid macular edema, subretinal fluid thickness, and taut posterior hyaloid and vitreomacular traction.
So
And neurosensory detachment. There is also a neurosensory detachment, no? Subretinal fluid or neurosensory detachment.
Yes, sir.
So that is also you can find. That's why the OCT based, the diabetic macular edema is classified into medical diabetic macular edema and surgical macular edema based on the OCT. So now how we are going to manage this case?
First, I'll tell the patient.
Can I jut in with one question before that?
Yes, sir.
Yes.
No, without an FFA, how can you differentiate between IRMA and new vessels? Not everybody has FFA. And not every place has FFA.
By looking the vessels, it will be between arteries and capillaries.
Without FFA,
they are
or some other way you can differentiate between a IRMA and a new vessel. Because a lot of times you don't have FFA, and other than that, systemic status also may not permit FFA in all patients. So clinically, it becomes very important to differentiate between a IRMA and a new vessel. There are a lot of points, but there are two key things clinically. Okay, anything which crosses a major vessel is never an IRMA. Okay.
Never an IRMA. Yes, sir.
And second thing is anything which comes out of the surface of the retina into the vitreous can never be an IRMA. You can see it clinically or on OCT. If these two things are there, it's always a new vessel and never an IRMA. Two clinical findings.
So being always elevated into the vitreous cavity, and with the whereas OCT, we can just try to map the new vessel also. IRMA will be first with the surface, and neovascularization will be elevated.
And IRMA will not cross a vessel and go to the other side. If anything is found straddling a vessel, it is always a new vessel. It cannot be an IRMA.
Okay.
I think someone has to mute. There is a lot of background noise.
Oh, whose background?
Yeah, sir.
Hello, Tima. Kasi,
Yes, sir. Yes, sir.
manager. Why you have put a Soundram, man?
என் போன் வந்து கனெக்ட் ஆகல சார். புது போன் ஜூம் இல்ல இதுல. டைம் ஆச்சு.
Oh, very good.
அதனால I took Soundram's phone.
Dima, one question, just a basic question.
Yes,
You
sir.
told now distant direct ophthalmoscope at arm's length.
Yes,
What's
sir.
the actual distance you have used?
66. What actual
66.
distance we have to use?
No,
It's
no.
the 66 centimeters.
Your distant direct ophthalmoscopy is normally done at what distance?
1 meter, sir.
1 meter. That is arm's length. That is
Yes, sir.
retinoscopy and all we do at 1 meter, man. The direct ophthalmoscopy instrument we are using at
25
what distance?
centimeters, sir.
That
25
means your
centimeters.
arm is only 25 centimeter.
No, sir.
Then that means you just tell distant direct ophthalmoscopy done at 25 centimeters.
Yes,
Don't
sir.
tell arm's length, forearm length, and don't tell.
Okay, sir.
Next, you have used this clinically significant macular edema. You are diagnosed with what? Diagnosis clinically you have done with what instrument?
Clinically, I confirmed with 90D, sir. Slit lamp biomicroscopy with 90D lens, sir.
So 90 diopter lens you have used.
Which is preferred?
What is the magnification
Which is
which you
preferred
are
for the
getting?
macula?
What is the magnification you are getting with my 90 diopter lens? Dima?
3
Three,
power 3
what?
magnification.
3 is 20 diopter lens
3x
indirect
magnification.
3 times magnification, the 20 diopter lens in indirect thermoscopy. What is the magnification you are going to get with the 90 diopter lens? How do you calculate magnification?
Magnification.
Hey, eyeball power, divide that by power
sir.
of the lens. Eyeball power is how much?
Eye divided by power of the lens. Simple.
60 diopters, sir.
60 by 90, how much?
But 90.
9.
0.6, sir.
So it is magnified and minified.
Minified, sir.
Then it's magnified with what?
10 into 10, sir.
With slit lamp. That's all we want. Hello.
Yes, sir. Slit lamp. Okay.
Already followed out. Some
Yes,
other
sir.
thing, never forget distant direct thermoscopy is done at actually distance, that is done at distance at 22 to 6 centimeters.
Okay, sir.
What is a method of parallax in distant direct ophthalmoscopy? Methods of parallax or displacement or differentiation by means of methods of parallax. Don't know. Regarding the level or position of opacities, man, in the media, whether it is in front of pupillary plane or behind the pupillary plane, that's all.
And what lens is preferred for a macula? 90D or 78D?
Actually, neither.
What would you prefer?
70,
70,
Yes. Yeah, because 90D advantage is you can see through small pupil, and that's only for the disc. For the macula, if you're commenting on the macular edema or any macular pathology, it's better to use a 78D rather than a 98D. But for a 78D, you need to have a dilated fundus exam, not in a small pupil. It's difficult.
Okay.
Emma, have you done OCT for this patient? Do you have the OCT images?
Yes, ma'am.
Can you please show?
Teman, you must ask for the history of hypertension also, right?
Yes,
You
ma'am.
said the diabetic history is for 5 years. Then you should ask for the history of hypertension also, right?
Yes, ma'am.
Is it important? Is there any study correlating?
Yes, ma'am. United Kingdom prospective diabetic study, ma'am. Control in systemic blood pressure will reduces the chance of reduces the incidence of
Rate of
reduces
progression of
the PRP.
PDR and the need for PRP.
Ma'am.
Okay. Strict control of hypertension decreases the need for PRP in PDR and also slows the progression of NPDR to PDR. We have the OCT, Manjula.
Show the OCT, ma'am. Go to the OCT.
Can we move to the next slide? Next, please.
This color coding is very important for the postgraduates. Can you
Tima,
just
Can you-
tell me?
Manjula ma'am, can you go to the fundus picture?
The
I mean, the
color
color coding diagram. The
diagram,
previous slide.
previous slide,
Diagram,
yes, yes.
diagram.
This
Yeah.
diagram, this diagram. Tima, I
Can you
want to
just tell
know,
the color codings?
Yes, sir.
you have drawn the
What is the what
vessels.
color?
Tima, you have drawn the vessels. The vessels
sir.
are up, even it doesn't reach your equator.
Yes.
That means remaining area, there is no vessel.
Avascular retina, sir.
Yes, sir.
Hello, you have drawn picture, just like that, no, even equator also it doesn't reach.
Hmm.
You should know how to draw the diagram first.
Okay.
This is very
First of all.
important for a postgraduate. The fundus diagram, the color codings, as sir said, the tracing is not, it's only up to the macula or the posterior pole, 30 degrees. It should be drawn up to the, what are the circles denote? The first circle, second circle, and third circle.
First circle denotes the posterior pole, sir. Second circle
Posterior
denotes the
pole,
ora serrata and equator,
Ah.
sir.
Equator.
Equator. Second circle denotes the ora serrata and third circle denotes the pars plana.
How do you know when you examine fundus, it is equator, man, inside the eye? What is a landmark to tell you it is equator, most probably? No. You have to, what? You know, ampulla of vortex ones, have you ever seen?
Ah, yes, sir. I'm not seen,
circle
sir. I
connecting all
read
the
about the
ampulla.
ample of
Circle connecting all the
Vortex
ampulla is
line.
called what?
Yes.
This is called equator. How many
So that is the
millimeters?
anatomical equator.
4 vortex points.
How many millimeter is the equator from limbus externally? How many millimeter
5.
is the equator from the limbus, the outside
Outside.
landmark? How many
Surface marking.
millimeter?
What we call surface marking. So what is surface marking of pars plana? Externally, pars plana, how do you surface mark?
With the caliper, sir.
Yeah, with the caliper, no? How, which is the landmark?
4 mm.
How do you, huh?
From the limbus,
Hmm.
we will mark 4 mm, sir. In case
4
of
millimeter.
phakic eyes. 4
Ah.
millimeter.
Why
mm
phakic and pseudophakic does it change?
Yes, sir. Pseudophakic, it is 3.5 mm.
No, that is for the pars plana vitrectomy where you have put the sclerotomy.
Okay, sir.
That distance is for sclerotomy, you putting pars plana. That doesn't mean the pars plana ends there. It's approximately, not approximately, the muscle ring. Means superiorly 5 millimeter, medially 5.5, inferiorly 6, and laterally, lateral rectus 7.7 millimeter. So that is approximately in the width of the pars plana. The pars plana is more posterior in temporally. Nasally, it is more closer because medial lateral is much closer to the limbus. And you can see the oral base and all very clearly in the nasal region, not in the temporal. That's why when you saw the fundus diagram here also, the oral base are usually marked on which the oral base are the ones you have put it in the pars plana, just like the beads. That is usually marked in the nasal region, not in the temporal. Because temporally the oral base are inconspicuous, not very clearly seen. So even the fundus diagram, this is wrong. The oral base has to be marked only in the nasal region.
Okay, sir.
So the
Fatima,
fundus
you
diagram
tell
is
me,
for the postgraduates.
you are not told about the equator distance from limbus. Okay, forget about it. What is the distance of the vortex veins, superior and medial, there is nasal, temporal, inferior nasal and temporal vessels from limbus? You tell me the distance from limbus, the exit of vortex veins. How many millimeter is from the limbus? Or at least you tell me from how many millimeter from the equator. You should read all these landmarks and all, anatomy, basics. You know, I got one book called Stellard Surgery, Eye Surgery. First 2 or 3 pages, you read that. Everything is given there. You can read if possible. If time permits, read.
Okay.
Okay, come to the OCT, ma. This fundus picture, you have to improve a lot. There's a lot of flaws in this fundus picture. So what are the color codings? You can tell the color coding before we move on to the next one. Microaneurysm.
Microaneurysms will be dark red in color, sir.
Hmm.
Hard exudates are yellow.
Hmm.
Cotton wool spots should be given in yellow color. Then
Cotton wool-
clinically significant.
Cotton wool spot yellow, both hard exudate and cotton wool spots yellow. Wow.
It should be hard exudates will be with discrete margins, sir, and cotton wool spots with ill-defined margins and variable in size, sir.
Mm-hmm. Okay. Fine. Let's move to the OCT.
Seema, one more thing, shall I ask Hasina?
Yes, sir.
Yes, sir.
Hasi, I have this girl. Suppose in diabetic retinopathy, this patient is having detachment. What color you will use?
Blue color, sir.
What about attached retina?
Red color, sir.
If you draw red color for attached retina in diabetic patient, how can you show hemorrhage and all?
It should be shaded
Hello.
in light red color.
Red color, you are told no background attached retina. I suppose I
Yes,
want to
sir.
show hemorrhage and all, hemorrhage also red color. How can I show the contrast and all? It's very difficult. That's why better option is in diabetic, when you draw the picture, no need to draw attached retina. No need for
Okay,
colorations. Whereas only RDK is okay, agreed. But in
Okay.
diabetic patients and all, nothing wrong. You just leave it. Only detached retina, only allow you can see. Or you can show that.
Okay, sir.
In the interest
Move
of
on to
time,
the-
can we move on to the management, sir?
Yeah,
Okay,
OCT
please.
management. Okay.
OCT.
Next slide.
Manjula madam, next slide. Next slide. Next slide. Next slide.
No OCT picture, nothing.
OCT.
You don't.
Yes, there. After thank you, sir.
After thank you. Okay. If time permits, OCT. Okay. Quickly, the OCT findings, ma, before time, because time is short, I guess.
Read the OCT, ma. Emma.
It's a OCT picture of right eye
Right.
showing normal foveal contour with the
Now,
healthy
Is
with the
it a
intact
normal contour?
RP.
okay. Is it a normal
With the
contour?
intact
Hmm.
with intact RPE with intact RPE and
Choroidal contour.
multiple hyporeflective and hyperreflective foci are seen within the retinal layers with the subretinal fluid collections in the beneath the fovea.
This is not normal foveal contour, but this is an altered foveal contour. Because you can see one side it is elevated and thickened, no? How can we say normal
Yes.
foveal contour? This is an altered foveal contour, first thing.
Okay, sir.
And you can see subretinal fluid also, means neurosensory detachment.
Yes, sir.
So this is not a normal foveal contour. This is an altered foveal contour.
Okay.
And you can see neurosensory detachment or subretinal fluid, and one side it's an elevated or thickened retina.
Yes.
So what are the hyperreflective dots which you see there? Thick ones.
The other hyperreflective dots are hard exudates, sir. Then hyporeflectives are the fluid collections in between the retinal layers.
Fine. Okay, next slide. Next OCT, other eye OCT.
OCT of left eye showing the altered foveal contour with the intact retinal pigment epithelium with multiple hyperreflective foci and hyporeflective foci in the retinal inner retinal layers and subretinal fluid collections seen in the foveal areas.
Okay. So how do you want to manage this case, ma? What is the treatment options?
I want to proceed with pan-retinal photocoagulation for both eyes.
But even before that, as a postgraduate, you should say systemic management first, right?
Oh, okay. Yes, sir. Yes,
Yeah.
sir. Systemic
You cannot
management.
forget to
Whether-
mention that. Yes, I would like, because the systemic parameters are totally deranged, 300, 400 sugars. So first you have to refer to the physician for systemic management, and side by side you can start the treatment. But you should never forget to mention that in a diabetic patient.
Yes, sir.
Fine. Next. For eye point of view, what is the treatment like?
Both eyes, CSME, how would you like to
You
treat?
said pan-retinal photodioglazing. Then?
Sir, I didn't get you, sir.
No, your treatment management for the eye. PRP, then?
PRP, then focal or grid lasers, sir.
So with the neurosensory detachment, would you do grid laser or
No,
the focal
sir.
laser? What
No,
are the
sir.
treatment?
Intravitreal anti-VEGF, sir.
Anti-VEGF. Sharmila, do we have time to discuss about the PRP laser, or you want to move to the next case?
No, sir, we have 5 more minutes.
Okay. So how do you start the
5 or 10
PRP?
minutes. We
Ma'am?
can.
Okay.
PRP, after anesthetizing the eye, patient has to sit comfortably.
What kind of anesthesia, ma'am?
Local anesthesia, sir.
Local anesthesia for PRP?
The topical anesthesia.
We have to be very clear. See, otherwise you should not comment on anesthesia. We know it's topical. If you say anesthetize, then you have to mention topical anesthesia. Right. Okay.
Okay, sir. Then with the organ green laser, we have to start our PRP settings from 200 spot size of 200 microns with the duration of 200 milliseconds and 200 millivolts. We have to start from the inferior aspects of the retina.
Why is that we should start from inferior?
As it is a case of PDR, there is a more chance of vitreous hemorrhage, and due to the gravity, it will get pulled over the inferior part of the retina. So inferior retina should be coagulated first, and then we have to proceed to the other quadrants in the following settings, sir.
And
maximum of nasally, we have to give PRP 500 microns in the 500 microns from the disc, then 3000 microns temporally from the fovea. Then superiorly, we have to give along the superior and inferior arcades.
And
About
this, but the energy you said start from 200 milliwatts, that's fine. But the duration should be, what are the parameters? Energy, duration, and interval. 3 parameters. Correct?
Yes, sir. Energy 200
The laser
millivolts,
parameter.
200 milliseconds with 200.
It's 200 milliseconds will be painful much. Usually between 100 to 150 milliseconds.
Okay.
And interval is?
How many sittings?
To one and 1.5 burns apart.
Okay.
And what is the interval, ma'am? Interval between the burns?
1 to 1.5 burns apart.
No, my interval, the duration. I mean, the laser parameters. Intensity, duration, and interval. Interval between one burn and the other burn. It's usually 300 milliseconds. Okay. And what are the types of laser you have? You have a PRP laser. You have now newer systems of laser, no? Multi-spot, monospot. Yeah. And the spot size, how will you determine the spot size? You're there, ma?
Yes, sir.
Yeah, the spot size is determined by the lens what you use. The lens has a magnification factor. There is area centralis lens. There is a trans PRP lens, mainster lens. So each lens has a magnifying factor. So normally the recommended spot size is between 300 to 500 microns. But depending on the lens, whatever you're using, you have to reduce the spot size in your slit lamp. It has usually the mainster and all has 1.5 magnification. So if you keep a 200 spots, it will be around 300 spot size on the retina. So based on the
Okay.
magnifying factor of the lens, you should titrate the spot size.
Okay.
Okay.
So what are the settings for the grid laser?
For grid lasers, it is 1000 to 200 micrometers and 0.1 seconds with
1000?
200,
What is
100 to 200.
Spot
What
size
is
100 to
1000
200
microns?
millivolts. Sir,
Okay, 100. Spot size?
spot size is 100 to 200 micrometers. Micrometers and 0.1 second
No.
with 100 to 200 millivolts.
It's
per
usually 100 power is 100 to 150. Spot size is 100 microns, not 150. It's 100 microns. And then it's a single spot. There is a multiple,
Yes,
you
sir.
can have a repeated laser or single. This is a single laser. Mono spot or single spot laser.
Single
And what
spot
are the laser patterns you have for macula?
focal
What are the
laser.
types of focal laser? Then grid laser and modified grid. We have three types, no?
Yes, sir.
Yeah. So in grid laser, what do you do? Where do you, grid laser is for what and modified grid is what? What is the difference between grid and modified grid?
Modified grid for papillomacular bundles. Sir.
No, ma. So grid laser is for thickened retina. Whenever you don't see the microaneurysms in fluorescein angiogram, you just
Yes,
do
sir.
the laser in the thickened
Laser.
area. That is called grid laser. Modified grid is use laser to the thickened area as well as to the microaneurysms. That is modified grid. And focal laser is just to the microaneurysms. Sharmila, Pozma.
Yes, sir. I think that's enough.
Okay.
You can sum it up, sir, like if you want to say some take-home points.
So take home point for the postgraduates is just stick to the basics. As said, the fundus diagram is very important for the postgraduates. Fundus diagram, I see a lot of flaws here. So the fundus diagram and color coding is very important. And then next thing is the classification of the macular edema, which is the erstwhile classification. Three types based on the center of the fovea, the hard exudates and the thickening. That classification is very important. And the FFA based classification, that is ischemic and non-ischemic, and the OCT based classification, which is what I said. And the fourth classification is based on the center involved or non-center, which is more of investigator driven, drug driven rather than clinical classification. So there are actually four classification of diabetic macular edemas that they should know from the basic to the recent advanced. And the treatment parameters, laser parameters, they have to be very clear about the laser parameters. In a macular laser, you cannot say 200 spot size. 200 is macula will be burnt, and there is a collateral damage also. So the laser parameter, they have to be very clear with the laser parameters. What is and simple, like the grid laser. And as BRB sir was asking about the basic parameters about the direct and distant direct. So the basics, advanced went down. Postgraduates, basics is more than suffice. So basics, they have to be thorough.
Okay, sir. Okay.
Thank you very much, sir.
Thank you. Thanks for the TNI for giving me an opportunity.
Thank you, sir. Thank you, Dr. Temangni, for the wonderful presentation.
Thank you, ma'am.
We move on to the next presentation by Dr. Shruti. Manjula, ma'am, can you share Shruti's presentation on branch retinal vein occlusion?
Okay, doctor.
Dr. Shruti, are you there?
Yes, ma'am, I'm there. Ma'am. Yeah. Am I audible, ma'am?
Yeah.
Okay. I'll start, ma'am.
Yes.
Good evening, everyone. This is Dr. Shruti Devi S., final year resident from Chettinad Hospital and Research Institute, and my presentation is on branch retinal vein occlusion. Next slide, ma'am. A small briefing on the history. A 41-year-old male presented with complaints of sudden diminution of vision in the right eye for 2 weeks, which was painless in nature. And there was no history of similar complaints in the past in the same and the fellow eye, no trauma history, no history of using glasses, no history of flashes and floaters, and no history of ocular pain. Next slide, ma'am. He was a known hypertensive for 4 years on medications. On general examination, patient was conscious and oriented, and vitals were pulse 80 per minute, BP 150 by 90 millimeter of mercury, and respiratory rate was 16 per minute. And systemic examination was within normal limits. An ocular examination, head posture normal, and both eyes were orthophoric, and extraocular movements were full and free.
You can just do the fundus examination alone. You can skip the anterior segment and all.
Okay, ma'am.
Next slide.
Now coming to the fundus examination, with respect to the right eye, on distant air ophthalmoscopy, red glow was appreciated. Next slide, ma'am.
The fundus photo?
On slit lamp examination using 90D lens, it revealed clear media, disc margins were well defined, and vessels were arising from the center of the disc, dichotomously branching with an altered AV ratio, and veins were tortuous, dilated, and engorged. And multiple flame-shaped hemorrhages were present below the supratemporal vascular arcade, involving the macula, below the supratemporal vascular arcade. And a few fluffy white lesions were present below the supratemporal vascular arcade, suggestive of cotton wool spots. And central retina showed thickening, which was showed a loss of foveal reflex, which was suggestive of the macular edema. And peripheries were assessed using indirect ophthalmoscopy and were found to be normal. Next slide. With respect to the right eye, on distant direct ophthalmoscopy, red glow was seen, and on slit lamp examination using 90D lens, media was clear, disc margins were well defined, cup disc ratio was 0.3 with a healthy neuroretinal rim. Vessels were arising from the center of the disc, dichotomously branching, and the macula showed foveal reflex. And peripheries were normal and assessed using indirect ophthalmoscopy. Next slide, ma'am. This is the fundus picture for reference. As you can see in the right eye, the veins are tortuous and dilated in the supratemporal quadrant, and you can appreciate the multiple flame-shaped hemorrhages, which is approximately 1.5 disc diameters away from the disc, involving the macula, and few fluffy white lesions are present across below the supratemporal vascular arcade, suggestive of cotton wool spots. And in the central retina, which is the macula, there is loss of foveal reflex. And the left eye, the fundus is normal. Next slide. Based on my clinical findings, the diagnosis is right eye supratemporal branch retinal vein occlusion with macular edema. That's it.
Okay. Does the patient have any systemic disorder, Shruti?
Yes, ma'am. He was a hypertensive patient for 4 years and he was on medications.
4 years, but the left eye fundus is normal. There are no
yes,
attenuation. There are no AV crossing changes.
Ma'am, the voice is not audible.
What are the causes for this branch vein occlusion? Most probable cause. You told no hypertension.
So usually we'll see the age factor and the underlying systemic factors like hypertension, hyperlipidemia, hypercholesterolemia. And if it's a young patient, we'll do a systemic workup for thrombophilia screening and homocysteine levels. Sir.
Homocystinemia, you're supposed to rule out.
If it's a young patient, sir.
Oh. Do you find any atherosclerotic patches in the retina vessels?
No, sir.
Why?
No, sir. In this patient, there were no AV crossing changes.
No, atherosclerotic patches. Atherosclerosis.
Yes, sir. At the AV crossing, there was occlusion of the
Shruti,
vein.
just know one thing. Atherosclerosis usually doesn't occur in retinal vessels. Usually.
Okay, sir.
Understand now? Usually
Okay.
will not see the atherosclerotic patches. Why this is a normal question, common question? Why superior temporal vein occlusion is more common?
Because AV crossings are numerous in the supratemporal quadrant compared to the infratemporals.
That's all. That's the
Yes, sir.
reason. That's the only reason. Your answer is the macular veins also draining into superior temporal vein area. So naturally, when a problem is there, you can have edema of the macula. The patient will come to you immediately. If a vein is uploaded somewhere else, naturally it may not come to you because the vision is not reduced. So one thing is what multiple AV crossings, and one more thing, patient is forced to come to you because of visual loss. That's the reason. Understand now?
Okay, sir.
In diabetes, the incidence of which vein occlusion is more common?
Central retinal vein occlusion, sir.
One of generally branches. Your answer is, of course, you may not know, superior nasal veins. That
Okay,
occlusion is very common in diabetic patients. Whereas
Okay, sir.
temporal vein occlusions are more common in hypertension. Understand now?
Okay.
Okay, this vein, branch vein occlusion,
Yes, sir.
they can produce neovascularization of retina or disc very commonly.
Yes, sir. They can predispose to
Which is
NVD
more
and
common?
NVE, sir. NVE, sir. Neovascularization
Sorry,
elsewhere.
NVD is more common with branch vein occlusion or say central retinal vein occlusion?
CRVO, sir.
Branch NVD T is more
Yes,
common with NV branch or CRV?
Central retinal vein occlusion, sir.
Sure.
Yes, sir.
Please remember, disc vessel is more common with branch,
Okay, sir.
whereas iris, angle vessels are very common with ischemic type of vein occlusion, central retinal vein. You know, some of the common questions we ask in the exams. To follow. Shruti.
Yes, sir.
Now you tell me,
Yes, sir.
what is the central vein, this vein occlusion study report tells you what?
Sir?
Study report, initial study report.
What does the study tell you?
BVOS study, what does it tell?
CRV occlusion study, branch vein occlusion study. You tell me something about the
Ma'am, the voice is not
initial.
audible, ma'am.
We have
What
studies.
is the
Shruti, he's asking you about the BRVO and the CRVO study. There's a BVOS and CVOS study results, 1980s. Do you know the study results?
Shruti,
Studies, sir.
you must
Yeah.
read all the study reports.
So first study was BVOS study, sir, which
tell me.
recommended grid laser.
When to give grid laser? In all cases?
When there is a macular edema, which is chronic for more than 3 months, and the vision is less than 612, sir. Best corrected visual acuity is less than 612. This was the finding which was done as per the BVOS study, sir.
Okay, I'll ask you. Suppose non-ischemic type of vein occlusion with the macular edema. Non-ischemic type of central retinal vein occlusion with the macular edema. When will you give grid laser?
Sir, actually, the first line of treatment is the intravitreal anti-VEGF. And in case the macular edema is going to be chronic and recalcitrant, then we can resort to grid laser.
See, the grid laser is not at all useful in non-ischemic type. Please remember this point. That's the study report. Grid laser is not at all useful in edema of the macula in non-ischemic type of vein occlusion. Understand now?
So can I get in for a point? She's asking you about the study recommendations of the BVOS study. What you are saying, we manage BRVO with macular edema today. But this is
okay.
At that time there were no anti-VEGFs.
Correct. This is just for exam purposes.
Yeah. So no, she went to anti-VEGF directly. And just to add one point to what VRV sir was asking about where you will get the new vessels. Simple way to remember it is new vessels always occur at the junction of the perfused and non-perfused retina. In a BRVO, you have a lot of perfused retina and a small area which is non-perfused. That's why you get the new vessels either at the AV crossing where the occlusion is, or if the occlusion is very close to disc, you get the new vessels at the disc. Whereas in the CRVO, your whole fundus is ischemic. There is no perfused area. So the nearest perfused area is only the anterior segment. That's why you get new vessels in the anterior segment. So that's always, even in diabetic retinopathy, you will always get new vessels only at the junction of the perfused and non-perfused retina. You won't get it wherever in any other place. In the middle of a non-perfused area or in the middle of a perfused area, we'll never get new vessels. That's a simple, that's a pathophysiology. Once you remember the pathophysiology, everything else will fall in place. There's no need to remember it at all once you understand this.
Shruti, have you ever seen fluorescein angiography being done? Shruti, you are muted. Shruti, you are muted. Hello.
Unmute.
Unmute.
Shruti?
Shruti,
She's answering on mute.
she is talking something.
Shruti?
Shruti, very good. Come.
Yes, sir.
You have seen fluorescein angiography, no?
Yes, sir.
Can I ask one simple basic question?
Yes, sir.
What will be the caliber of vessel in color fundus photo compared with the fluorescein angiography caliber? What will happen to the caliber of the vessel? In which it is large, in which case it is normal? Color fundus or fluorescein angiography?
Fluorescent.
What? Caliber will become larger or smaller in fluorescein?
It will become larger, sir.
Where? In fluorescein.
Yes, sir.
Why?
It'll be more prominent, the caliber
No.
of the vessel in fluorescent angiography.
No, that is caliber is compared to color photo, it is small. That's what you want to tell.
No.
Okay, sir.
No,
In
I'm
other
not
ways-
telling the answer. I'm asking you. You want to tell this. The caliber of vessel in angiography is smaller or larger compared to color photo.
Color fundus, sir. Smaller,
What?
sir.
Smaller,
Smaller.
why? Why smaller? Why larger? You must explain. You know one thing, Shruti?
Yes,
In
sir.
color
Because
photo, in color photo, fundus photo,
Yes, sir. Yes,
what
sir.
you are seeing is the RBC moving in the center. Whereas in angiography, the plasma proteins, protein-bound fluorescein, they can emit fluorescence. So plasma also you can see, it appears larger. In fluorescein angiography, the caliber will be larger because the plasma also you can see.
Okay, sir.
Whereas in color, you cannot see that. To follow?
Okay, sir.
These are some of the basic questions we'll ask you. Understand now?
How will you
Okay, sir.
differentiate ischemic BRVO from non-ischemic BRVO?
Yes, sir.
How will you differentiate ischemic from non-ischemic BRVO or perfused and non-perfused?
So for ischemic BRVO, there's going to be more than capillary non-perfusion areas will be more than 5 disc diameters in case of ischemic, and non-ischemic is going to be less than
Shruti, break.
5
It's beginning broken.
disc diameters of capillary non-perfusion areas on FFA.
Dr. Shruti, your net connection is not that good.
Sir, hear me,
You'll do better off if you switch off your video and use audio alone.
sir.
If you switch off your video and use only audio, it will be better off. Switch off your video.
You can, yeah.
Now just use only audio, you'll be much clearer.
Can you repeat
What
that
are
answer, Shruti?
Yes, ma'am.
BRVO?
Yes, ma'am. In ischemic BRVO, like on fundus fluorescent angiography, there's going to be more than 5 disc diameters areas of capillary non-perfusion, ma'am.
What are the causes for diminution of vision in BRVO?
Edema, sir, or there can be a foveal hemorrhage, or there can be a macular ischemia, sir.
Shruti, your
Or a
voice,
vitreous hemorrhage.
your voice is breaking. So, sir suggested that you kindly switch off your video so that your audio can be clear to all of us.
Yes, ma'am.
Thank you. Yes, you
Okay,
can-
now tell me.
Yes, ma'am. Turned off the video.
Yeah, now you're clear. Kindly proceed.
Yes, sir. Okay. ma'am.
Causes, now tell me. Macular edema, ischemia, then
Causes of macular ischemia, macular edema, vitreous hemorrhage, and vitreous hemorrhage, sir, and foveal hemorrhage.
foveal hemorrhage. Okay, how will you differentiate whether it is
Just
acute?
one actually. Saravanan, sorry.
Old.
If it really gets bad, they can go in for a tractional retinal detachment. Don't forget
Yes.
that.
Yes, sir.
Okay, how will you differentiate the old retinal vein occlusion from acute? Acute, you know, you will have intraretinal hemorrhages and all. But old, how will you diagnose?
Yes, sir.
What are the
In
Saravanan. அவங்க என்ன பேசுறாங்கன்னு புரியுது.
Signal strength is not good, sir.
There can be dot and blot hemorrhages, sir. If it's going to be a chronic retinal vein occlusion, and macular edema will be recalcitrant.
How will be the caliber of vessels? Will there be any sclerosis or fresh hemorrhage?
Long-standing cases, the vessels will be sclerosed.
Some music is coming. Music.
Your voice is not clear, Shruti. It's breaking very badly, actually. I think, Saravanan sir, you can give the answers yourself.
I'm sorry for the.
Okay, it's okay. Don't bother.
Okay, you can see the sclerosed vessels and you can see the collaterals, telangiectasic vessels, microaneurysms, all in favor of chronic BRVO or confined to the segment which is affected. Plus, of course, macular edema.
Yes, sir.
And in chronic
Okay,
macular edema, you'll also get ERM formation and you'll get secondary macroaneurysms in BRVO. It's a little too technical, not for your level, but still, just to complete.
Okay, sir.
Okay, how we are going to proceed? Investigation and management.
So first I'll do systemic investigations.
Okay,
And
your
then-
patient is a non-hypertension patient. Okay, it's very well known. Okay. You
And
said about
since
in
he's
young.
a young patient, I'll look on to other.
I think Saravanan, we are
Levels.
better at telling the points. Her line is pretty ordinary.
Okay, part.
No.
Patient has severe macular edema.
Either ask
Yes, sir.
or- One thing I wanted to ask or probably even say is, because your line is bad, we're all talking about CRVO and BRVO.
Yes,
How
sir.
is tributary vein occlusion different from a BRVO?
So in central retinal vein occlusion,
No, not
organs are
central,
involved,
not
sir.
central. Tributary vein occlusion.
Tributary vein occlusion.
Tributary vein occlusion. So in tributary vein occlusion, there'll be like capillary dropout areas and more vascular leakage.
In terms of what complications it can produce, how is a tributary vein occlusion different from a BRVO? What is a tributary vein occlusion? First you answer that question, then the next answer will follow.
Tributary vein occlusion.
Basically, it's a small tributary, most
Major
likely
branches.
in the macula. Okay.
Okay, sir.
So what will it cause? When small branch in the macula, one small tributary of a vein in the macula is blocked, what will it cause?
Leakage, sir. Capillary leakage.
And then what will the leakage cause?
Increased vascular permeability and edema, sir.
Edema. Okay. So is the tributary supplying a very large area or a very small area?
A small area, sir.
Will it cause new vessel formation?
Yes, sir.
No, most likely no, because it's a very small area. That small area of capillary non-perfusion most likely will not produce a new vessel formation. So tributary vein occlusions are very safe in the aspect that you need not follow them up for new vessel formation. You treat the
Okay,
macular
sir.
edema and that's it. They'll never develop a new vessel. Whereas branch retinal vein occlusion, even if they are away from the macula and they don't have macular edema, you should either follow them up on a regular basis for new vessel formation down the line, 3 months, 6 months also later, or you should do a FFA to see how much of capillary non-perfusion is there after the hemorrhages have resolved. And if the study criteria is, if there are more than 5 disc diameters of new vessel, the capillary non-perfusion, it is justified doing a sector laser to prevent new vessels. But we don't
Yes,
do
sir.
that anymore, but still theoretical.
Okay, sir.
So that's the difference between a tributary and a branch vein occlusion.
See, can I ask you one thing?
Yes, sir.
You counted respiratory retinol. Really? Is it really you have done? You told respiratory is 16, something like that you told.
Yes,
Did
sir. As a
you-
part of systemic
No, no.
examination.
Did you really do that?
Yes, sir.
Sure.
Yes, sir.
I don't think so. Hello. And you told something about flashes and all in the history, no? No history of flashes and all.
Yes, sir.
Can I ask you one question? Suppose I see flash in the temporal aspect of the field. Where
Yes,
is the
sir.
actual irritation in the by the vitreous in the to the retina? Which quadrant? Suppose I got a flash in the right side, right temporal aspect. Where is
Yes,
the
sir.
irritation? The irritation by the vitreous on the retina.
So opposite to the site of occlusion, sir.
No, not. I am asking you. Flash in the temporal quadrant. Where is which quadrant is the irritation?
Nasal quadrant, sir.
Sure.
So like which supratemporal and infratemporal quadrant, sir?
No,
Like
that
it's
is
going to
okay.
be.
Temporal quadrant is having generalized temporal quadrant is having flashes. Where is
Yes,
the
sir.
irritation? Which quadrant is irritation?
Temporal quadrant, sir.
Temporal quadrant flashes. In the retina, where is irritation?
Not asking about a field defect. He's asking about flashes of light. You're confusing it with field defects.
Okay, sir.
Shruti, you know one
Yes,
thing.
sir.
Flash has got no localizing value.
They're always projected temporally.
Temporally.
Okay, sir.
Only field you can tell correctly. Temporal means you can tell nasal retina like that.
Okay, sir.
Flash has got no localizing value.
Okay, sir.
So your patient got macular edema. How are you going to manage? After doing all the systemic workup and evaluation, controlling the systemic diseases, now you're as an ophthalmologist, what you have to do?
I'll proceed with the OCT macula, sir. Quantify the macular edema. So here for this patient, spectral domain OCT was done, sir. So this OCT, it shows disorganization of the retinal inner layers, and there is cystoid spaces, and there's intraretinal hemorrhage, and there's a hyperreflective lesion at the fovea, suggestive of foveal hemorrhage, sir. And the foveal contour is also lost here.
Okay.
So what will you do?
But the first
So
line
we are going to
of management would be intravitreal anti-VEGF agents, ma'am.
What regimen you will follow, ma, for anti-VEGFs? There are different regimens. Are there any set criteria? We have a monthly injection.
Yes, ma'am. Monthly intravitreal injections for 3 months, and then as and when needed, ma'am.
Okay, suppose the patient after receiving 3 doses of intravitreal anti-VEGF, there is
Yes,
no
sir.
reduction in the there is a recurrent macular edema. How are you going to proceed?
I'll proceed with intravitreal steroids, sir.
Straight away intravitreal steroid.
Yes, sir.
You don't go back and investigation. What is the role of FFA in the BRVO?
FFA, it helps us to know whether the macula is perfused or non-perfused, sir. If it's going to be a macular ischemia, there's going to be no active intervention, and observation is the management, sir.
Other than macular edema, macular ischemia, what else? What information you can gather from the FFA?
We can gather about the capillary non-perfusion areas, sir, in the peripheries.
Okay.
Okay, before going intravitreal steroid, after 3 doses
sir.
of anti-VEGF, your FFA shows a lot of capillary non-perfusion areas. So what will you do now?
I would resort to scatter laser photocoagulation, sir, to address the neovascularization if it's present.
What is meant by sectoral photocoagulation?
We'll do it on the periphery, sir. So here the spot size is around like 100 to 500 micron size.
Periphery or your
at the
quadrant?
at the neovascularization area, sir.
Is it similar to the full PRP in the PDR, or is it different from the PDR?
It's different, sir.
You want to address where the CNP areas are?
Neovascularization is actually.
Okay. Okay, sir.
Okay, so you have the sectoral PRP, still the persistent macular edema is there. So you are going to, what's your next line? How you have to manage that?
So yes, sir. So the voice is breaking, sir.
So cystoid recurrent myeloma, how you are going to manage?
I will resort to intravitreal steroids, sir.
Okay, what is the role of research indication in surgery?
Manjula ma'am, I think it's VRV sir's line which is. Yeah. Yes, sir.
Yes, sir.
For macular edema, when will you advise? What is the indication?
Sir, for macular edema?
Yes.
I'm sorry, I didn't get it.
Indication of vitrectomy in management of chronic macular edema.
If there is epiretinal membrane, we can do vitrectomy, sir. When there is epiretinal membrane, sir.
Okay, then thought posterior highlight, then VMT.
The surgical macular edema, we go for vitrectomy.
This is obstruction to the macula area, perfusion. So there is 2 other indications for the vitrectomy in macular edema. What are the complications of ischemic BRVO?
Ischemic BRVO can lead to ERM, sir. Then tractional retinal detachment, sir.
No, ischemia will lead to new vessels that will bleed vitreous hemorrhage and that will resolve to form tractional eye. Okay, okay, sir.
Just to complete that, Dr. Shruti, do you know any other role of surgery in BRVO other than surgical macular edema?
Sheathotomy can be done, sir.
Just to complete it.
And radial optic neurectomy can also be done.
For a CRVO.
Okay, sir.
In the interest of time, can we move on to the next presentation, sir, with the concluding remarks?
Why sheathotomy? That's last question.
Sir, to release the pressure within the adventitial sheath shared by the artery and the vein.
Good. Pathophysiogenesis is at the AV cross junction.
Yes, sir.
Okay. So you should read about the studies as VRV sir is mentioning, asking. You should read about the studies, the cases, pertaining to the cases. BRVO. Okay. Geneva study, Bravo study, all studies.
Yes, sir.
Yeah, you should know about it. Okay. For the want of time, we can move to next.
Okay, sir.
Thank you so much, sir. Thank you, Dr. Shruti. We move to the next presentation. Disc edema for evaluation by Dr. Niveta from RLG.
Niveta, you can start now.
Yes, ma'am.
You have the screen or have you sent it to Manjula?
Yes, ma'am, I have the screen.
And you start.
Good evening, sir and ma'am. Coming to my presentation, fundus examination of my patient. Examination of right eye using distant direct ophthalmoscopy done at a distance of 30 centimeters showed a red fundal glow. Moving closer to the eye, disc media was clear. Disc was vertically oval and edematous. The disc was hyperemic, and the cup was filled, and peripapillary edema was seen. Vessels arising from the center of the disc, branching dichotomously with an arteriovenous ratio of 2:4. Venous dilation was seen. Venous tortuosity was seen, and obscuration of vessels at the border of the disc was seen. Macula FR was present, and spontaneous venous pulsation was absent. The above findings were confirmed with using a 90D lens and a slit lamp biomicroscopy. Examination of the peripheral retina using indirect ophthalmoscopy was normal. Examination of left eye using a distant direct ophthalmoscopy done at a distance of 30 centimeters showed a red fundal glow. Moving closer to the eye, the disc was vertically oval and edematous, and disc was hyperemic, and it showed a filled cup. Peripapillary edema was seen. Vessels branching dichotomously from the center of the disc. With an arteriovenous ratio of 2:4. Venous dilation was present. Venous tortuosity was present. Obscuration of vessels at the margin of the disc was seen. Macula foveal reflex was present, and spontaneous venous pulsation was absent. This is the fundus picture of right eye. And this is the fundus picture of the left eye. My provisional diagnosis is bilateral disc edema under evaluation, and my first differential diagnosis would be papillary edema by Frison's staging, stage 3, that is moderate papillary edema.
Nivedha, you told about the pulsations absent, no spontaneous.
Yes, sir.
Did you try giving a pressure and saw the
Yes,
pulsation?
sir.
You were
Yes,
able to
sir.
elicit or not?
No, sir, I was not able to elicit it, sir.
Even on pressure.
Yes, sir, even on pressure, sir.
But you were color the diagram, no, that whatever the diagram you have drawn.
Yes,
You
sir.
have told no venous dilatation, no AV ratio, no nothing is seen. Everything appears normal for me. You are not shown.
Okay,
See,
sir.
of course, color photo agreed. But
Yes,
in the
sir.
picture you have drawn, no. It's a
Yes,
AV
sir.
ratio. I don't think so. They have 2:4 and all. Something
Okay, sir.
wrong you have done. Understand now? You have to change it.
Okay, sir.
I think you're not depicted the venous dilatation. You're not
Okay,
depicted.
sir.
Look, the caliber looks almost the same. What's the significance of these vessels? Why do you have to look for these venous dilatation? And anything related to the caliber of the vessels? What significance in the differential diagnosis? What has signified?
Sir, in case of papillary edema, the CSF pressure will be transmitted to the veins, sir.
No,
So
no, I'm
that
talking
will
only
cause
related to
venous
the.
engorgement.
No, I'm talking only related to the caliber of the vessels. What differential diagnosis will it give a clue about? Suppose your calibration, your arterial calibration is very, very narrow.
Sir, my differential diagnosis will move towards malignant hypertension, sir.
Yeah,
So,
that's it. So you're the caliber of the vessels. So you don't expect a venous dilatation, and the arterial attenuation will be narrow over the vessels, over the disc in a case of a malignant hypertension. And what other clues will you find in this thing related to the vessels? What else will you look for?
Sir, arteriovenous crossing changes will be present in case of malignant hypertension, sir.
Okay.
And associated features like cotton wool spots and flame-shaped hemorrhages will be seen in both papillary edema as well as
in both,
in
it can be seen in both. What's significant in case of malignant hypertension? Disc edema, malignant hypertension come away from the disc. What else do you see related to the macula?
Sir, in macula,
macular findings in papillary edema per se, and macular findings in malignant hypertension.
Sir, in macular edema, in papillary edema, we can find macular fans, okay. And the macular fan will be prominent in the nasal side of the discs. I mean, towards the disc. And in malignant hypertension, hard exudates can be seen, sir.
So what is that called?
Nasal side of the disc. What do you tell?
Nasal or not the disc? Macula.
Nasal side to disc or nasal to the macula?
Nasal to the
disc and
macula, sir.
Okay, this is a macular fan. So what is the other one called?
So macular star.
Yeah, okay. What's the difference? What's the pathological difference between a macular fan and a star? Pathological difference.
Macular fan is actually venous. They are small bulging, sir. Whereas a macular fan is actually exudates.
What bulging? No. Don't talk specifically. Don't on bulging. What's bulging there?
Are they hard exudates or something
or not?
else? That's what.
The question is, are they hard exudates or not? With regard to a macular fan.
No, sir. They're not actually hard
So what
exudates.
are they? So what are they?
So they are lipid.
Lipid.
No,
hard
no,
exudates
no.
also lipids.
Other than lipid, other hard exudates. Star than hard exudates. Macular fan is fluid-filled vacuoles. Fluid-filled. Yes, small vesicles or vacuoles, which you see there on nasal to the macula. This is a macular fan. Whereas a star is different, which has hard exudates there.
Okay.
So that's the basic difference between these two.
Okay.
So what stage do you say your papilla edema is in?
Sir, according to Frison's scale grade, I would say it is in stage 3, that is moderate papilla edema, sir.
What are you listing? Why do you say it's moderate?
Sir, because in my fundus, the disc margins are 360-degree disc margins are blurred, and an elevation of the disc was seen, and there is enlargement of size of the optic disc, and there is peripapillary halo and finger-like projections are seen, and there is obscuration of major vessels at the margin of the discs.
Did you do a visual field? Did you do a visual field for this patient?
Yes, sir. There was a. I don't have the report with me right now, sir.
But did you do it or not?
Yes, sir. Yes, sir. There was enlargement of blind spots, sir.
What else can you see? What other field defects can you see in case related to papilla edema?
Sir, in case of papilla edema, there may be infranasal step defect, and in case of chronic papilla edema, 360-degree constriction of peripheral fields can be seen. And if macula is involved, central field of vision also will be affected, sir.
Suppose you have got a tumor inside the temporal lobe. Can you get that field of defect or not?
Sorry, sir.
Papilla edema usually associated with space occupying lesion. You know that.
Yes, sir.
Intracranial pressure.
Yes,
so wherever the tumor is there, you can have field defect at that time related to the visual pathway also.
Yes, sir.
In addition to enlargement of blind spot, you can have that.
Yes.
Why do you get enlargement of blind spot in papilla edema?
Sir, it is due to the peripapillary retinal detachment, sir.
And then?
And there will be displacement of the retinal layers, sir. And
displacement of retinal layers from where?
So from the discs. From the peripapillary area.
From the disc margin, correct one, hello.
From the disc margin.
When do you, why do you say it's papilla edema? The associated intracranial pressure should increase, you know that?
Yes, sir.
Why in malignant hypertension papilla edema you call it as? What's the reason for malignant hypertension papilla edema? Because you should have associated raised intracranial pressure, no?
Yes, sir.
But malignant hypertension also you call it as papilla edema. Is it papilla edema or something else?
No, sir. That is hypertensive optic neuropathy, sir.
No, I'm asking you, can you call it as papilla edema? If it is papilla edema, what will be the reason for your increased intracranial pressure in hypertension?
Sir, in hypertension, due to the arteriolar.
No, you're not understanding his question. You don't understand his question.
Niveta, he's asking, can it be called papilla edema and hypertension? If that is called papilla edema, then what is the reason?
What is the reason for raised intracranial pressure in hypertension?
No, sir.
You raise the question, a hypertensive, what will cause raised ICT in an uncontrolled hypertensive patient?
So, next question. What is the type of necrosis taking place in malignant hypertension?
Pathological. So I was asking the pathology.
What is the type of necrosis occurring in the choroid, which are manifesting as L-Schnick spots and Seegrease sign? What type of necrosis is that?
Sorry, sir.
Hello. You know, pathogenesis of papilloma is axoplasmic stasis. You know that?
Yes, sir. Yes, sir.
Why hypertension also you got axoplasmic stasis? What's the reason?
So it is due to the ischemia that is happening on the vasa nervosum, sir.
No. Why in a case of hypertension, there is malignant hypertension, axoplasmic stasis occurring in the disc level? What's the reason?
So due to the ischemia of the optic nerve.
How the ischemia occurs?
Sir, in hypertension, there will be arteriosclerosis that
No, I'm asking
happens.
arteriosclerosis, sir.
Increase in the medial hyperplasia will happen, and that will
malignant
narrow the
hypertension patient, arteriosclerosis, if it is there, they may not develop. The all no sclerosis, that is younger persons only are prone to get malignant hypertension. Without sclerosis, they can undergo spasm, which can lead on to acute what? Fibroid necrosis, affecting your choroid. Choroid supplies your prelaminar, laminar portion of optic disc. Naturally, when that area is affected, the axons in that area cannot conduct axoplasm, get accumulated there. That's the reason. Raised intracranial pressure is because of cerebral infarctions. Same malignant hypertension. They can produce cerebral ischemia, leading on to edema of the brain. No, you must read hypertension not thoroughly.
What are the ocular causes of disc edema? Ocular causes.
So the ocular causes, papillitis can be seen, sir, and anterior ischemic optic neuropathies.
Ocular causes, okay, within the optic, within the intraocular portion of the optic nerve.
Papillitis.
Intraocular. Okay.
Neuroretinitis.
Any of the inflammatory cause within the eyeball you can get? Can you get in a posterior uveitis, disc edema?
Yes, sir. In case of neuroretinitis, we can get disc edema, sir.
Posterior uveitis, can you get a disc edema or not? It's a very simple clinical question.
Yes,
yes
sir.
Or no?
We can. Yes, sir.
Yes, yeah, okay. And in case of ocular hypotony, can you get?
Yes, sir. We can get, sir.
So these are some of the intraocular causes of this thing, of disc edemas.
Okay, sir.
What are the preclinical? Sorry, sir.
Sudden increase of intraocular pressure can get disc edema. You told now ocular hypotony you can have.
Yes, sir.
Sudden increase of intraocular pressure can produce disc edema or no?
No, sir. It will not produce, sir.
No.
No, sir.
Have you ever seen an acute congestive glaucoma fundus sometimes?
Yes, sir.
Think before you answer.
How
Think
the
before
fundus
you
be like?
answer. I think then you're not seen a case of a disc in a case of a acute congestive glaucoma. I think you're not dilated and seen a fundus. Just seen only the anterior segment. Now you're not seeing the posterior.
There are vascular
There will
signs
be
for disc
corneal
edema, right?
edemas.
Niveda, what is ophthalmomalacia?
Sir? I'm sorry, sir.
Ophthalmomalacia. In that case also you can have disc edema. Can you tell me what is ophthalmomalacia? Of course, don't tell it is keratomalacia. Hello, that is different. You don't know. The changes occurring as a result of ocular hypotony, they are all called as ocular ophthalmomalacia. Hey, short notes, man. Niveta.
Sir.
Short notes.
Okay,
ophthalmomalacia. If I set a paper, my first question is this.
Okay, sir.
Idea is what? Nobody should write. Niveta?
What's a sequence of disc edemas? Which margins get? What is the sequence? Which margin gets edematous first, and what's the sequence? How does it progress?
Initially, it starts in the lower pole, sir, and then
No,
in the upper.
no. Then you're talking about ISNT rule. There's no ISNT rule here. That's with glaucoma.
Upper pole, lower pole, nasal margins, and the last would be
No.
temporals.
It starts usually with the nasal. You look for the nasal first. It starts nasally first of all, initially.
Okay.
Then you have an upper, then lower, and then temporal. Okay, it starts nasally. It's not against the ISNT rule.
Okay.
So what if you see a disc with the cup is filled, but it's not hyperemic? What will you suspect? The disc is filled, the margins are blurred, but it's not hyperemic. There's normal caliber of vessels. What will you suspect? And
Maybe a case of pseudopapilledema, sir, in case of crowded disc.
Okay. Where do you get pseudopapilledema?
So, pseudopapilledema can be seen in hyperopic disc, sir. There will be a small disc.
Then?
And in case of tilted disc, and in case of myelinated nerve fiber and optic disc drusen.
Drusen, yeah, okay. What is a buried drusen? Do you know what is a buried drusen?
So, buried drusen is found in optic disc, and it will mimic true case of papilledema, sir.
What is a buried drusen? When do you see it? At what age group do you see it? And when does it manifest?
And most importantly,
okay, what is the classical diagnostic point to diagnose a buried drusen?
Yeah. How do you diagnose drusen, optic nerve drusen?
How do you diagnose? Very easy, very simple. The thing early, even a buried drusen you can pick it up very clearly. Very simple test. What is the investigative procedure? Of choice, if at all you're given a choice.
Investigation which you
So
can do here?
OCT autofluorescence can be done, sir.
Yeah, good. Okay, yeah, fundus fluorescence.
Other than that,
Other than that, B scan can be done, ma'am, and OCT optic nerve head can be done, ma'am. That will show a lumpy, bumpy appearance in case of optic disc drusen. And in B scan, hyper echogenic lesion will be seen in B scan.
Why do you see hyperechogenic areas?
At the optic nerve head, sir.
Why do you see the hyperechogenic areas?
Because it is calcified, sir. Drusens are calcified.
Yeah.
Niveta, you told lumpy bumpy, no?
Yes, sir.
In which some other problem you can have a lumpy bumpy disc? In which systemic condition you can get? You told now drusen, man.
Yes, sir.
But a similar appearance, lumpy and bumpy disc, classically seen in. No idea. Sarcoidosis, man. Hello. They will ask you. Now, what is plerocephalic edema? In papilledema patients. Plero, plerocephalic edema.
Is it a true papilledema or a pseudopapilledema? What is sir asking? Is it a true papilledema or a pseudopapilledema?
With a plerocephalic edema, I don't know.
Cephali. Do you know what's the word? The word itself and its meaning, no? Cephali.
Yes, sir. Cephali is head.
So you should know papilledema, raised intracranial pressure, is because of a space occupying lesion. That is, you call it as plerocephalic edema, brain tumor, man. So,
what's the significance of a B scan, ma, in this thing, papilledema? Significance of a B scan?
So, B scan can pick up the optic nerve sheath diameter, sir, and it can be used even in case of minimal papilledema. It can pick up the fluid levels, sir. So we can plan the procedure accordingly, sir. If the patient is having significant vision loss and if there is increase in the optic nerve sheath diameter, we can plan the management accordingly, sir.
And what will you do? Will you go ahead and do a thing, LP initially to check for the pressure?
Sir. No, sir. First,
before doing an LP, what precaution will you take before doing this thing? LP.
So first, I have to do an MRI brain with MRV, sir, to rule out any space occupying lesions, sir.
Yeah, good. Okay. So if you have a space occupying lesion, what will happen?
Why you're asking for MRV?
There will be herniation, sir.
That's a good question. Why do you ask for an MRV?
In order to rule out any cerebral venous thrombosis, sir.
Okay, good.
So that MRV has to be.
So what will happen if you have an SOL and then you do an LP tap?
There will be herniation of contents, sir. So we are basically creating a low pressure area by LP, and the contents will herniate through into
What
the
herniates? What herniates?
The brain stems.
Uncle herniation.
Uncle herniation.
So what's the opening pressure? What's the opening pressure in LP? Beyond what point?
Beyond 25 centimeters of water in adults and 28 centimeters of water in children will be considered as papillodemas.
What is the crescentic sign? What is the crescentic sign?
So, crescentic sign is seen in B's cancer. It is an echogenic area around the optic nerve, sir. That is, it shows the excess fluid collection between around the optic nerves.
Where do you get the situs inversus of the vessels of the disc?
Sorry, sir.
Situs in what do you call situs inversus of the vessels? Disc vessels. What is situs inversus? Where do you find it? Where do you get this condition? Situs inversus.
Nivetha, how do you differentiate in FFA papilledema or papillitis?
So, in case of papilledema, in early stages, capillary microaneurysms can be seen on the discs, and in late phases there will be leakage of dye from the discs. In case
Papillitis
of
also you can have leakage. Papillitis also you can have leakage. Papilledema also you can have leakage. How do you differentiate? You know one thing, Nivetha?
Yes, sir.
Your answer is, sir, it's very difficult. Of course, clinically and all you can find out. But in FFA, something difficult. Sometimes in papillitis, we can have some sectoral ischemia may be there. That's all. Want to follow?
Yes, sir.
How do you differentiate post-papilledemic optic atrophy from post-papillitic optic atrophy?
Sorry, sir. Can you please repeat the question?
Post-papilledemic optic atrophy from post-neuritic optic atrophy.
So, post-papilledema, it will be secondary optic atrophy, sir.
Post-papillitic also secondary only.
Secondary.
Hello.
That's also
Yes.
secondary only.
Yes, sir. Associated
No,
features
disc findings. Talk about the disc findings. How will you establish the diagnosis? You have a
Atrophy is second place.
secondary optic.
Atrophy is second place already.
Okay,
You are
sir.
seeing now, but don't bother about bilateral and all these things. That's different. Just by
Okay.
seeing the disc and some vessels and all, can I tell is it possible or not?
So associated features like Peyton's lines can be seen in case of
Better lines.
in papilledema.
Your
And
answer
RP
is,
changes
hello,
may be.
Nimetha, your answer is, sir, something difficult again.
Difficult questions are all repeatedly asking. Difficult.
Difficult.
Sir, that's a way of learning.
But the
Actually.
most important point is what? Sometimes you can see what is called as reverse taper sign in post-neuritic optic atrophy because of inflammations. Normally the arteries, near the disc, they are larger compared to periphery. But in this neuritis, post-neuritic case, the arterioles near the disc become narrower. That is
Because of
called
the
reverse
sheathing.
taper sign.
That's because of the sheathing of the vessels.
So can we give the concluding remarks, sir?
Yes.
It's 9:10, sir.
Nivetha has done very well because I've seen this girl many times.
GOH, sir.
GOH. I think last month I came there, no, Nivetha?
Yes, sir. Yes. Yes, sir. Yes, yes.
So she's been handpicked, sir. Handpicked to present the case, sir.
I don't know.
Yes, sir. Thank you very much, Nivetha. That was a wonderful presentation. Thank you, Parthiban sir and VRV sir. We move on to the last final presentation, retinal attachment case by
Neela Priyadarshini.
Neela Priyadarshini.
Yes, ma'am. Yes, ma'am.
Yeah, go ahead.
Please start, please.
Ma'am, slides.
Manjula ma'am, can you share your screen and upload her slides, please? Thank you.
Thank you, ma'am. Shall I, sir?
Yeah, go ahead.
Good evening to our respective panelists. Myself, Dr. Neela Prideshni from MMCHRI. My topic today is retinal detachment. Demographic details. The patient name is Lalita, 19 years old female from Kanchipuram. Fundus examinations. The right eye fundus photography. Media clear. Disc normal. On distant direct ophthalmoscopy, grayish reflex seen in right eye and red reflex seen in left eye. On distant direct ophthalmoscopy with near to face, red reflex, grayish reflex seen in right eye, disc normal, media clear in left eye, red reflex seen, media clear, disc normal. Next slide, ma'am. On right eye, fundus examinations, media clear, disc normal, 0.3:1 cup disc ratio, NRR healthy, margins distinct, grayish white, opaque, dome-shaped ballooned elevation seen in retina from 12 o'clock to 8 o'clock position with the macula off. A single hole is noted in 11 o'clock position. Vessel near optic disc normal, AV ratio 2:3. In left eye, media clear, disc normal, 0.3:1 cup disc ratio, NRR healthy, margins distinct, vessels normal, AV ratio 2:1, periphery normal, macula foveal reflex present. Next slide, ma'am. My diagnosis is right eye regmendagenous retinal detachment with both eyes simple myopia. Thank you.
This is the refraction.
Ma'am, vision, ma'am. On slit lamp examination, vision right eye 2/60 with no improvement in pinhole, no improvement with glass, near vision N6. Extraocular movement full and free. Lids normal, conjunctiva normal, cornea clear, AC normal depth with Van Gogh heading 4. Iris normal depth, iris normal color and pattern. Pupil reacting to light. Lens clear. Goldman applanation tonometer at 12 noon. It is 10 mm Hg in right eye. In left eye, vision 5/60 with PG of -3.75, improving to 6.6, near vision N6.
The patient is myopic, Priya. How old is the patient and how myopic is he?
Ma'am, she is 19-year-old patient, ma'am. 19-year-old.
Okay.
You go back to your fundus drawing.
1 year she was a known case of. Yes, sir. I'm sorry.
Manjula ma'am, can you go back a few slides? Yeah, this slide. This should be fine. Yeah. So, Dr. Priya, I'm going to ask only very practical questions. Where is the break in this?
Yes.
Like RD?
In 11 o'clock position, sir.
Are you sure
Simple.
that is a causative break? Know what a causative break is? It means more than one break in RD, but usually there is one break which is causative, one or more breaks which are causative. Are you sure this is a causative break? This is what is causing the RD. You don't understand this question, huh?
Sir, with
Are you sure that hole at 11 o'clock is what caused the retinal detachment and not any other? You need not look for any other hole. Are you sure?
We have to check for any lattice degeneration. Since the patient is a myopic patient, I have to check for any lattice degeneration, peripheral degeneration, retinal degeneration presence or not. I have to look for it.
No, Dr. Priya, sir is asking which is the primary break here. He's asking which is the primary break.
Primary break. Which is the break which is causing the RD. So you put it in your diagram, you showed a hole at 11 o'clock and then you drawn a retinal detachment around it. So are you sure this is the hole which is causing this retinal detachment? Simple question. Or do you have reason to suspect there can be some other hole?
No, sir. This
Very
is
simple question. Straightforward.
There is a reason, some other hole. According to Linkoff's rule,
that is exactly what I'm coming
We
to.
have to check the
So
periphery.
is this obeying Linkoff's rule? That is my question. That is what I was coming to.
Sorry, the break.
So the question I was
asking is this
is the retinal detachment obeying Linkoff's rule?
Sir, network issue, sir. I couldn't hear anything, sir. Could you please repeat? Sorry, sir.
I will.
Manoj, sir, can you repeat the question?
Sir, Dr. Shriram is asking, is this retinal detachment obeying Linkoff's rule?
Obeying, sir. Obeying Linkoff. Yes, sir. Yes, sir. I'm able to hear, sir.
Okay. Is it obeying Linkoff's rule?
It's obeying Linkoff's rule, sir. But this may be not the primary break. This is the only break I could access with scleral indentation, sir. We have to look for any other break also.
Okay. In any case of retinal detachment, how do you look for retinal breaks?
Using Linkoff's rule, we have to check for the retinal break, sir.
Okay. By what examination?
In a scleral indentation method, in indirect ophthalmoscopy, scleral indentation method, I have to look for the peripheral any break is present or not. I have to check.
Okay. According to Linkoff's, how many configurations have been described?
6 configurations, sir. 3 for superior retinal detachment, 3 for inferior retinal detachments.
And if it's a total retinal
Modified
detachment?
Linkoff's.
Okay.
If it's a total retinal detachment? Actually, Linkoff works only for partial RDs, not for
partial
total.
RDs.
That's why. So this patient, you said the patient, he or she is a myope, right?
Yes, sir.
You know the left eye's refraction.
Yes,
Then
sir.
Let us assume the left eye was emetropic.
Okay, sir.
Is there any way of ascertaining whether right eye was myopic or not?
Maybe, yes, sir. There may be a cause for unilateral myopia also, sir.
Yeah. How do you prove it, or how do you confirm or disprove it?
I'll check for vision first of all. If it is vision normal, and I'll go for fundus
vision with
examination.
hand movements.
Okay, so vision with hand movements and fundus examination. I will go and check for any myopic fundus pathology, pathological myopia fundus changes like lattice degeneration, snail tract regeneration, presence or not.
More importantly, posterior pole. Disc, macula, myopic changes.
Myopia disc, cup disc ratio. I will check.
Even
small disc will be myopic disc will be small inside, small disc.
Those things. Myopic disc, other eye disc will look normal. This side disc will look myopic, have a peripapillary crescent.
Peripapillary crescent.
Macular degeneration. Whatever part of the retina which is attached, you find severe tessellation and myopic degeneration in this eye. Other eye will be normal. And failing all this, any other way you can ascertain, because I'm not a teacher, I'm not an examiner, I'm a clinician. So if I'm going to do surgery for this patient, I'll want to tell the prognosis. So even if retina attaches, if the eye is densely ambulopic, he's not going to get much vision at all. So any other way you can ascertain whether one eye alone is highly myopic in the presence of an RD? Don't think too much. Very simple thing. What is myopia?
When the parallel rays falls in front of the retina.
Okay, that is optically. Physically, anatomically, what is myopia?
Axial length of the eyeball we have.
How do you measure the axial length?
A scan.
Yeah, but A scan will not be correct because there's an RD here. At least an ultrasound A scan will not be right. It will give you a false reading. Yes. An optical A scan, yes, it will work, but an ultrasound A scan will not work. The simplest way is to do a B scan of both eyes.
Okay.
You will clearly see one round oblong eyeball if the eye has got a very high myopia. I'm not talking about a difference of 1 or 2 diopters. I'm talking about emetropia in one eye and minus 16 to 20 in the other eye. So that really carries a significance when you're going to operate on this patient. He'll be a densely ambulopic patient and he will not require much vision at all. So prognosis wise, that carries very serious implications. Okay. So I don't know whether I should go into this, Manoj. Please stop me if I'm going too much into retina.
No, please go ahead, sir.
No, because this patient, normally retinal detachment happens because of PVD induction, right?
Yes, sir.
You know that pathology, vitreous syneresis, PVD induces, causes
yes, vitreous syneresis, PVD.
This patient is a 19-year-old, right? If I'm not mistaken.
Yes,
so
sir.
do you think this patient had a PVD, a retinal hole, and a retinal detachment, or something else is happening?
She's a 19 years myopia, so maybe there may be PVD subset followed with that only. Myopic fundus basically, so degenerations is more common with that retinal RD.
Manoj, your inputs?
No, you carry on, sir. You go ahead with your question, then we will ask. Then I'll ask.
So usually these patients never have a PVD. Young patients never have a PVD. RD can happen either with or without a PVD. Patients who are older, pseudophakic, aged patients who have a PVD, you will see a PVD there, you will see a vice ring. You will usually find retinal tears, horseshoe tears, operculated holes, giant retinal tears. These things, these breaks are caused because of a posterior vitreous detachment. Whereas this is an atrophic hole. Okay. This is because of a localized vitreous. There is a hole in the retina, but a hole alone will not cause an RD. Probably there is localized vitreous syneresis around that hole, which is causing the fluid vitreous to go under the retina and cause an RD. So this is not very progressive. So before we go into management, any other thing to do? Did you examine the other eye completely? Because you have fundus only of one eye. Does the other eye have any?
It was normal, sir. Nothing. Fundus was very normal. There is no break, no detachment.
Most important to examine the other eye, the periphery with scleral indentation to make sure they don't have any lesions. Okay. That's it. Other than that, it's straightforward. For that thing, you have to go for management. Before that, Manoj, you have anything else in examination, pathophysiology, anything else?
Yeah, you told what diagnosis, Priya?
Right eye regmentogenous retinal detachment, sir.
One more, you added something.
Myopia.
Simple myopia, you told.
Simple myopia, sir.
What is simple myopia? What is pathological myopia?
When the refractive, when it is up to -4, more than -6
that is
diopter.
okay, but now you have got detachment on all posterior segment problems. He has got some vitreous problems.
Yes,
how can I say it's simple?
If the refraction is more than -6, will go.
No, that is okay, man. Refraction status. But the problem is when to call pathological, man, when there is an associated problem posterior to the equator. He's having some changes, in the retina also. You told he may be having something. You are telling he has developed a hole.
Atrophy of the retina may develop.
No. What is actual meaning, definition of pathological myopia? So my advice is better.
Lies in the name. The answer lies in the name itself.
When the axial length of the eyeball is
No, that is okay, man. Best
and there is some
option is,
pathology.
that means
Yeah,
you
answer lies in the name.
avoid the use of
When there
simple
is
myopia here.
any pathology.
Also, Priya, you've done nice presentation, but the diagnosis of retinal detachment, especially when you have partial retinal detachment, never completes whether the macula is attached or detached.
Attached or detached.
Okay. Yeah, that's a very important point because which retinal detachments are emergency? Macula on or macula off?
Yeah.
Which one you like to repair immediately?
Nadi, which is threatening the macula.
I'll clarify his question, Dr. Priya. He is asking. His question is, if this patient had a macula on and 6/6 vision with correction, would you operate that person first? Or there's another patient whose macula is just detached and he has hand movements. Will you operate that patient first? You have a choice. It's a Saturday morning. You either operate one patient today, one patient on Monday. Patient comes in on Saturday.
I will go for option to take any chances for the macula to get fixed.
No, your audio wasn't clear. Macula on or off? Who first?
On.
On, yeah. Right answer. Good one. Why? We want to clarify?
Because I don't want to take any chance for that patient to get the macular involvement, sir.
Good.
Okay, good point. Go ahead. You want to describe about the management of this patient? How will you like to manage this patient?
Sir, I will confirm my diagnosis with fundus photography and B-scan. After that, I will go for management. For holes, I will go for laser photocoagulations. Surgeries include pneumatic retinopexy and scleral buckling surgery.
No. This patient, how will you manage? This patient, how will you manage?
Particular patient, you restrict your management to this.
You always restrict yourself to your presentation patient.
Sir, for this patient, I will go for pars.
You're breaking up a lot. Maybe turning off your video might help. Yeah.
Sir, I will go for this patient. I will go for pars plana vitrectomy with PCFL with endo laser and silicone implants.
Okay. Why? Why not a scleral buckle?
Because macula is
Okay, this is beyond PG level, but still I will clarify why I asked that question.
scleral buckle when it is a giant tear or.
No, remember I asked you one question whether there's a PVD in this patient or not, and I told you there will not be a PVD in this patient.
Sir, pars plana vitrectomy because scleral.
You remember I asked you a question whether there's a PVD in this patient or not, and I told you it's very unlikely that this patient has got a PVD.
Yes, sir.
So in those cases, you go only for a scleral buckle. You don't go for a vitrectomy, at least conventionally. Now people do vitrectomies for everything, but that's beyond the scope of this discussion. You would generally go for a scleral buckle. Though this particular patient, don't go too much into this, but this particular patient, you can also do a pneumatic retinopexy. It is possible because it's a single break. Okay. Do you know where all you can do a pneumatic retinopexy?
Yes, sir.
The indications for pneumatic retinopexy.
Sir, when there is a break larger than 1 clock hours. Sir, am I
audible? More than 1 clock?
Larger than 1 clock hours or multiple breaks exceeding more than 1 clock, over the 1 clock hours.
I think you got it.
Yeah, contraindication.
Totally the other way around.
Sorry, sir. When there is a single break which is superior to the 8 clock. Okay, so sir, indication for pneumatic retinopexy is when there is a single break in superior 8 clock hours, or if it is a break not more than 1 clock hours or multiple break within 1 to 2 clock hours, and in phakic patients as well as in
where should the RD
free from any systemic.
Where should the RD
Sorry, ma'am?
Superior RD or inferior RD? Which RD? That should be the first indication. Yeah.
Superior, ma'am. Superior.
Actually, not necessary, ma'am. RD can be anywhere. Okay, where the breaks are which matter. Sorry to say that.
Okay.
RD can be anywhere because it can be this same patient can have a break at 11 o'clock. There need not be any superior RD. There can be a small track of fluid coming temporarily and have an inferior RD. As long as you're sure the causative break is in the
superior.
Very simple. Upper half of the fundus.
Okay, sir.
And why should it be in the upper half of the fundus for pneumatic retinopexy? What is the logic?
Because it's a air will float, sir. It won't settle down.
Yes, rather, so, not air.
Gas, sorry, sir. Gas, it will float, it won't settle down. So if it is in the superior 8 clock hours, it is an indication for pneumatic.
So if your gas will float, your gas will always go to 12 o'clock. Correct?
Yes, sir.
So you said superior 8 clock hours. So this is the right eye. Imagine he has a break between 8 and 9 o'clock. Imagine this person has a break. There's no break at the 11 o'clock position. There's a break between.
Expansile, sir. Gas will get expansile.
So your gas will expand to come down to 8 and 9 o'clock to tamponade that, close that break, or what do you do?
I will do the scleral surgery. So
no. You're doing a pneumatic retinopexy because you said pneumatic retinopexy between top 8 clock hours. You can do pneumatic retinopexy. That's correct. You're absolutely right. Point well taken. But if this person, instead of the break, as you showed now, it's not at 11 o'clock. The RD is also not looking like this. There's a break between 8 and 9 o'clock. That fits within your indication for pneumatic retinopexy, right?
Yes, sir.
So how will the gas, you said the gas will always float up. How will it go and press the brake, which is between 8 and 9 o'clock? Because up is 12 o'clock, no?
Yes, sir.
So how will it press the brake there? Unless the gas goes and pushes the brake, or to use the right technical term, tamponades the brake is not going to. So how will it close the brake? How will it tamponade the brake at 8 o'clock or 9 o'clock? If your gas is only going to float up.
Surface tension.
Simple. Physics.
Mechanical closure. Gas will produce mechanical closure and.
No, you're thinking too much. Simple. You put the patient in the left lateral. 9 o'clock.
Positioning.
almost. Yeah, position the patient.
Positioning, sir.
Okay. So that is the reason why you should not do a pneumatic retinopexy when the break is in the inferior cloaca, 4 cloacas. Why? Because obviously you cannot have somebody upside down for 3 days.
3 days, yes.
Okay.
Yes, sir.
So
Priya, who was the first person who told to seal the hole for RD surgery? Who was the first person?
Am I allowed to answer, sir?
Priya,
Yes, sir. Yes, sir. I'm here, sir.
who was the first person who told you have to close the hole for the success of RD surgery? Prior to that, they were doing so many things.
The landmark thing, because until then they thought there was fluid
Sir,
under the retina. They used to create holes to settle a retinal detachment.
Sir, my trial, I am trying that answer. Jewel is Gonin.
Yeah. Gonin.
Right.
Gonin.
Gonin.
Yeah. Have you ever used indirect ophthalmoscopy, binocular indirect ophthalmoscopy?
No, sir, but that is a principle, Gonin principle for...
No, that is okay. Gonin principle is agreed. Okay. Have you ever used indirect ophthalmoscope?
Indirect ophthalmoscopy. Yes, sir.
You are using, you know.
Yes, sir. Indirect ophthalmoscopy.
Who popularized it? You tell me the name of the person. Yeah. These things may not be asked. By chance, if I want, I will ask you these questions. History.
I'm not sure, sir.
Charles Sheepens.
Okay.
And who is the one who first said, invented pneumatic retinopexy? Can you give a hint? So, name of a popular hotel. And the surname of a popular model also.
Hilton, sir.
Yeah, not bad. I think that model clinched that answer, right?
Yes, sir.
Good.
So, any closing remarks from Dr. Manoj Khatri?
Yeah, Priya, a nice presentation. But remember, always remember, your examiners will not like straight away very high-fi treatment in terms of pars plana vitrectomy. This is a young myopic patient. The treatment by default remains treatment of choice by default remains scleral buckling surgery, and you should be very well versed with scleral buckling surgery principles, because all the examiners, whether we are doing scleral buckling nowadays or not doing scleral buckling nowadays, will like to know the principles of scleral buckling surgery. That is point number 1. And pneumatic retinopexy and all, it's not, it will come as a third choice of treatment for this patient to be offered. Okay. So assess the patient, see what is the diagnosis, what is the finding, and then only offer the treatment. In retinal detachment surgeries, unless and until the buccal is contraindicated, for all examination practical purposes, scleral buckling is the treatment of choice. Okay. Unless and until in the scenario where you cannot do the scleral buckling surgery, then only vitrectomy and all those other things take place. Okay. Yeah, very important in exam. Any retinal detachment case, first treatment of choice to any examiner should be told scleral buckling surgery. Yeah.
Always talk in relevance to your case. Because first when you asked about management, you said laser first. You have a subtotal retinal detachment there. There's no way you can do laser for this. I agree that's a list of things you can do, but always talk with relevance to your patient. Okay. Because that's the first answer which will come out of your mouth, and that is what will stick in your examiner's
Sir, not able.
Pardon?
Sorry, sir. Not able to hear, sir.
No. Always talk with relevance to your patient when you're asked about management.
Sure, sir.
Because this is a case presentation. It's not a general viva where somebody is asking how all you can manage retinal detachment. So your first answer was laser photocoagulation. There's no way you can do laser for this patient. So when that answer, the first word
fundus drawing also slightly incomplete. Okay, you need to do many things in the fundus drawing itself. That we will discuss sometime later. Okay, maybe we'll have a class on fundus drawing. Right from the date, nothing has been mentioned. So there are many flaws in the fundus drawing itself. So try to correct on all those aspects as well. Everyone is looking only for basics. They are not looking for any high fundus stuff. Okay, they are not looking for what gauge of vitrectomy you are going to use and all those kind of things. But basic principles, be calm, composed. You presented very well and don't get misled by the leading questions from the examiner. So you try to catch hold of the question and then answer it. You did a very good job.
Thank you, sir.
Okay,
Thank you so
nothing more to add from my side. I think Dr. Sharmila, you can take it over now.
Thank you very much, Manoj sir and Dr. Sriram Gopal and VRV sir for the wonderful discussion. Can we have a round of applause for all the brave hearts, Dr. Temangani, Dr. Shruti Devi, Dr. Niveta and Dr. Neela Priyadarshini.
Thank you. Thank you for this
And
opportunity.
They are very good. All of them were very brave. They came out here and
very
faced
impressive.
all the heat. But I am very, it's always a journey. Learning is always a journey. It's never complete. So you're taking a first step. So don't get disheartened by all these questions and all. All of us have been in this for decades, so we're able to ask these questions. Probably I didn't even know 1/10 of what all was asked to y'all, and y'all answered also. Most of it y'all answered. I didn't even know 1/10 of all this when I was doing my PG or even my fellowship for that matter.
We are really privileged and honored to have VRV sir, you know, like a very passionate teacher like VRV sir join us. What were you saying, sir?
He's saying it's getting recorded. What I'm saying is the truth. I didn't even know 1/10 of all this, which was answered when I was doing my PG.
That is the truth. These are all hardcore retina specialists. And we have a very passionate teacher, VRV sir, who has been teaching for years together. He accepted at the last minute and cancelled his class and joined us today. And wonderful moderation by Dr. Sivagami.
To be there with the same, always blessing to be there associated with VRV sir. Thank you, sir.
Yes.
Thank you.
Thank you, Professor Parthiban sir. Thank you, Kasinathan sir, Sriram sir, Saravanan sir, Manoj Khatri, and wonderful moderation by Dr. Sivagami. Can we have the certificates presented to the presenters, Manjula ma'am? And special thanks to Numerotech Sai sir and Manjula ma'am for the wonderful coordination. Manjula ma'am, can we have the certificates?
Sure, doctor.
So these certificates will reach you. We'll send it across to you.
All presenters can turn on their videos.
Yeah. For a group picture. Yeah, so Dr. Shruti Devi, Dr. Temangani, Dr. Neela Priyadarshini, and Dr. Niveta. So these certificates will reach you. We'll send it across to you. Thanks to the moderator and the panelists. I think it's 9:30, time for dinner, so we'll wind up. On behalf of the Tnoa, I thank you all for your wonderful participation.
Thank you.
We had a good
Thank you, Dr. Sharmila, for all the coordination.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, everyone. Good night.
Thank you, everyone.